So next up, Chris Parrish, an occupational therapist from Ohio Health, is going to be giving us a talk. He graduated from the Medical College of Ohio with his master's program degree in occupational therapy in '03, and he works as an OT at Ohio Health in home health and the outpatient departments. He completed an executive certificate in home modifications from the University of Southern California's Gerontology Center in 2012, and also earned the designation of a certified aging in-place specialist from the National Home Builders Association. He works closely with patients, families, and building professionals and other healthcare professionals to incorporate key strategies to increase the safety and independence of individuals living in Central Ohio. He was recently awarded the Award of Excellence from the Ohio Council for Home Care and Hospice for his innovative work on home modifications. And we're really lucky to have him here to share his expertise with us today. So please join me in welcoming Chris Parrish.
Thank you very much and good afternoon. I'd like to speak with you on the topic of home modifications and how you can integrate this intervention into your daily practice to help empower your patients with MS and taking control of their homes. So the objectives I hope to accomplish today are, first of all, defining what home modifications are, and also identifying key team members in the home modification program. Secondly, identify essential components of a comprehensive home modification program. And finally, identifying common barriers to success with home modifications, and also learning ways of overcoming these barriers. So you heard a little bit about my background, but I wanted to share with you my journey to where I'm at today with my home modification program. So being the son of a carpenter, early on I was able to see how my dad was able to make changes to our home environment and other work sites that he was on to help individuals, helping them with safety, helping them with accessibility. And as I became an occupational therapist in 2003, I quickly was able to see the correlation between how an individual is either set up for success or failure based upon their home environment. So as I became an occupational therapist, I saw that benefit of how we can make changes to our home environments to help our patients be successful. And in order to increase my knowledge base on this topic, in 2012, I, as she mentioned earlier, attended the Executive Certificate in Home Modification program through the University of Southern California. What this allowed me to do was to gain increased knowledge base on completing better home assessments, learning how to obtain funding sources for these type of changes, also looking at the ability to market such a program, and probably most importantly, learning how to communicate with builders and other professionals on job sites. Learning to mesh what we look at as therapists to what they're looking at from a code standpoint, and trying to mesh those things to really meet the patient's needs. So after I completed that program, I slowly began to implement some of those things into my practice. But it really wasn't until 2014 when I became a full-time home health employee through Ohio Health that I really began to see the benefit of this program. So after getting my feet wet in home care, spoke with my manager in 2016 and shared with her my vision on implementing some of these programs a little bit more thoroughly and more consistently with my patients. So she was definitely on board with it, and not only saw the benefit for possibly home care patients, but also saw the benefit of patients throughout the Ohio Health system. So what we decided to do, we spoke with Dave Rupp, who was a manager for outpatient, and shared with him my vision, and he was definitely on board with it as well. So in 2017, we began to roll out a pilot program, allowing me to go to homes of individuals who have been identified to have environmental barriers, to help them eliminate these barriers to access community easier, decrease risk of falling, help with conserving energy, things of this nature. So at this time, since its inception, I've actually completed over 200 visits, specifically looking at home modifications with these individuals. And I've rolled out my services to a variety of service lines throughout Ohio Health, including home care, outpatient, and some of the neurospecialty clinics as well. So when we look at home modification, we obviously want to look at what is the current housing stock, and as well as what are our patients wanting to do. And currently there is a really big shift towards providing community-based programs and community-based services, really wanting individuals to live at home, if at all possible, as opposed to looking to being transitioned to a skilled nursing facility or other environments. We also know that patients really want to remain in their own homes if at all possible. There's been a couple of studies that have been done, one by a Harvard housing study that looked at and found that 75% of individuals 50 years or older want to remain in their own homes. A similar study was done by AARP and found that 87% of individuals 65 and older want to remain in their own home as long as possible. Why is that? Home, as you know, provides a sense of security, a sense of safety. They've developed a community, possibly with their neighbors and other individuals around the area, and be uprooted out of that community setting. And that sense of security is traumatic to them. Unfortunately, one barrier that we have working against us is that the majority of homes throughout the United States are older and have features that become barriers for persons with disabilities. As you can see by this visual representation here, only 57% of existing homes in the United States have at least one universal design element. So what is that? What's the definition of universal design? It's the design of buildings, products, or environments to make them accessible to all people regardless of age, disability, or other factors. So they're inclusive in nature. They would be beneficial to you or I, as well as individuals with disabilities as well. Examples of that would be things such as no-step entries, single-floor living arrangements, switches or outlets reachable from any height, things such as extra-wide hallways or doors. Another statistic here that's interesting is that only 3.8% of housing units in the United States are suitable for individuals with moderate mobility difficulties. And generally speaking, disability really impacts many of us. 22% of individuals in the United States have some form of a disability. And when looking at those disabilities from a functional component, 13% of those individuals that we've identified have some type of mobility deficit. 10.6% of them have cognitive difficulties. 6.5% of them have difficulty living independently or accessing the community. 4.6% have visual deficits, and 3.6% have difficulties with self-care, doing things such as bathing, dressing, vital components of their daily life. And you probably recognize this slide from earlier. Individuals with MS are also at risk for these type of disabilities as well because of these symptoms that they have. Common symptoms with MS individuals include numbness and tingling, pain, as we heard earlier, bowel and bladder dysfunction, weakness, muscle spasms, and walking difficulty. So all these things included really create barriers for them to be able to interact with their home environment. So what can we do as clinicians? It's really important to take a comprehensive approach to manage MS. It involves the expertise from multi-healthcare professionals, having them attend things such as MS clinics so multiple individuals can see them and use their expertise to help them out. The goal of these programs is to provide a comprehensive, coordinated care to manage the disease, promote comfort, function, independence, health, and wellness. As clinicians and as therapists, we can provide care to these patients, promoting function through the traditional rehabilitation model, such as being seen in outpatient care or in the acute care setting, but we can also provide the care and bring the care to them by following more of a community-based model, completing things such as home care and completing interventions such as home modifications, assessments, and interventions. So what are home modifications? They're defined as adaptations to the living environment designed to increase usage and performance for the individual, look to improve safety and security, and provide overall support for a more independent living environment. Due to the complexity and specialization of home modification projects for those with progressive conditions such as MS, most successful projects are built around the partnerships that leverage each professional's expertise, experience, and knowledge. It's important to assemble a team that serves the unique needs of the patient. Common home modification team members include, on the healthcare side, very frequently an occupational therapist, possibly a physical therapist, seeking the assistance from a physician, a nurse, or a social worker. And when looking at housing team members, we often see a contractor on board, possibly an architect, interior designer, as well as an equipment specialist. These are just a few of the common team members that you might see in a home modification project. No matter who those individuals are in a professional component, it's always important to involve the patient and the family members at the core of this team. They're the individuals that are living in this environment, and they can give us key feedback on what difficulties they're having so we can make individualized recommendations for them. Another important point to make is that if at all possible, involving a CAPS team member or a certified aging in place specialist within your team is beneficial. This is a designation provided by the National Association of Home Builders. It's helpful in that it increases the knowledge base of not only building professionals, but as well as healthcare professionals on specific person or kind of personalized modifications and changes that need to take place. Another interesting point to make about the CAPS designation is that because this is a national recognized certification, they have a database in place that if you have an individual outside of your normal comfort zone as far as knowing what contractors are in place, a lot of times I may get questions, do you know of a good contractor that's in Michigan or in Florida, someone of that nature? I don't really know where to start, so this is a great opportunity to go on the CAPS website and be able to get at least a starting point for individuals who have been through this training, who have a better understanding of patient-specific modifications and how they need to be taking place. Another important point to make is that home modifications were found to be most impactful when integrated in with multidisciplinary interventions. So as the occupational therapist, if I'm completing home modification recommendations, I often pull in a physical therapist to help that individual with strength and balance training, looking at pulling in a nurse, a physician, maybe a pharmacist for disease and medication management, possibly a speech therapist for addressing any cognitive disorders that individual may have, and probably very importantly, a social worker to assist with funding and resource options. As I mentioned before, it's important to involve the patient at the center of the recommendations. One such program that looks at home modifications that does a very good job of integrating in more of a patient-centered interventions is the CAPABLE program. CAPABLE stands for Community Aging in Place, Advancing Better Living for Elders. It was developed by a nurse at Johns Hopkins University, and it's a client-directed home-based intervention to increase mobility, functionality, capacity to age in place. It's a 5-month program that's comprised of an occupational therapist, a nurse, and a handyman. And the key component of this program is that it utilizes a client-driven goal setting and brainstorming strategies to overcome barriers and gain more independent living. I'm not sure how well you can see this at the back, but it's a diagram of the program. And it integrates a biobehavioral environmental interventions into the program, looking to accomplish things such as home care and assistive devices, training in the use of compensatory strategies, increasing physician communication, looking at medication review and adherence and support, strength and balance training, as well as problem solving with depression intervention and pain management. What they found by integrating these interventions into the program is overall they found some proximal outcomes such as decreasing disability with ADLs and IADLs, improving mobility for the individual, improving overall quality of life, and improving environmental safety. The distal outcomes they found was that it improved the reduction of emergency room visits, decreased hospitalizations, decreased nursing home admission, and overall decreased cost to the individual. So it's a very comprehensive program, and something that we're looking to possibly pilot from a home care standpoint within our Focus on Fall committee. So it's something that's on the horizon possibly for us. Research into how housing improvements can directly impact the health and care outcomes. It's an important and an increasing area of transdisciplinary research. It really ties the links between health and housing and indicates that housing interventions are important to the mechanism of health maintenance and overall improvement. So just a few research studies that were done. The first one looked at a scoping review of several evidence-based interventions within home modification and looked at some key themes that emerged when looking at these overall research studies that were being done. So things such as looking at how home modifications improved function, self-care and independence, health, overall physical health and well-being of the individual, how it reduced caregiver needs. But the strongest experimental evidence was found that it had been conducted in the relation of fall prevention. So a study that specifically looked at fall prevention was the CDC Compendium of Effective Fall Interventions in 2015. What it found was that there was essential components that looked to reduce the risk of falling, and one of those being home modifications. Interestingly enough, it identified most success with the home modification programs was having an occupational therapist complete the home modifications as opposed to other disciplinary team members. The role of occupational therapy in home modifications has been well documented. Home modification interventions delivered by an OT have been found to greater reduce the efficiency in falls, as well as improving function for those individuals. Home modifications are truly about finding the fit between the person and the environment. An occupational therapist understands very greatly how an environment can make things easier or harder on the individual, specifically if they have disabilities or are elderly. An effective home modification program should include, first and foremost, a comprehensive evaluation and assessment, looking at not only the home environment itself, but the patient's physical abilities and how they interact between the two. Also looking at identifying the need for any changes that need to take place, helping that individual select and acquire the products that are necessary. If funding resources are necessary, pulling a social worker on board to help with those things. And the home modification team should also look at the identification and oversight of adaptations or remodeling to the home environment. Probably one of the most important points that's missed quite often is providing patient and caregiver education after the equipment has been provided or the modifications have been completed. Especially because many times modifications can take several months to complete. Given our current healthcare model, it's sometimes difficult to be able to stay in on a case with that individual and provide that care 2-3 months down the line. So being able to circle back around with that individual once those modifications have been completed is a very important point to make, because many times if equipment is just provided to the patient and adequate training is not given, or if a patient has not walked through their new environment with grab bars in place, roll-in showers, things of that nature, they may not know how to use that properly. So as I mentioned, the assessment should take on two different components. Looking at the housing survey, so looking at the condition of the home. Does the patient own or rent the home? Looking at the overall grounds, as well as external and internal traffic. Surface materials, such as what does the flooring look like, what does the ground look like to get in, what kind of condition is the cement or blocks in to ensure that there's not trip hazards present, as well as looking at the overall rooms, as well as looking at safety and security of the home. Secondly, we want to do the healthcare professional assessment. So we want to look, from an occupational therapy standpoint, looking at a patient's vision, hearing, cognition, balance, strength, all those things that are integral in seeing how they interact with their environment. Then it's important to sit down with the patient and to determine the who, what, and when. So who are the team members that need to be involved in the process? What modifications need to be completed? And when can we start these changes? Is it something that we can just order equipment and bring it in? Or is this going to be a long-term modification process that needs to take place? I made a point here that it's interesting to note that although many regulations exist for commercial and public properties in regards to maintaining accessibility, private dwellings are almost unregulated. So it's important to utilize the ADA, or American Disabilities Act, the American National Standards Institute, state and local codes, to utilize those things as guidelines to help guide our decision making and helping that along. So we also want to look possibly at discussing client objections. So if a patient, you're making a recommendation for a certain piece of equipment or a certain change to the home, if they're having objections, and many times I see a patient having objections because they're worried about how the changes to the home might affect others in the home to be able to integrate their normal activities. So what we may want to do is, well, as I spoke about earlier, integrating in universal design features whenever possible to help increase that inclusion. So when selecting and acquiring products, modifications such as installing a roll-in shower with a shower chair and grab bars, as well as possibly a stairway lift, can help an individual with MS conserve energy, manage fatigue or weakness, or other common MS symptoms. One important thing to note about the stair lift, though, if a patient is having postural difficulties, if they don't have good balance in sitting or standing, I would not recommend a piece of equipment such as this. You would maybe look at trying to integrate them to be able to live on the first floor as possible, looking at how we can manage modifications to allow them to utilize a bathroom or bedroom on the first floor. If a patient has issues with balance, as well as issues with gait, coordination, muscle tone, or strength, these issues can be mitigated with the help of appropriate modifications such as handrails or grab bars. And if a patient has been confined to a wheelchair or a scooter, the installation of a ramp or possibly a vertical platform lift means that they can gain easier access or entry to the home, allowing them to maintain greater community access and avoid isolation. So we talked about some larger modifications that can take place to help individuals, but honestly, simple changes can help as well. So making sure pathways are free of clutter, rearranging furnishings to improve the flow of the room, or possibly increasing lighting to an area that can make significant improvements in function. So as you can see here, this is the before and after. And although this is a stock photo, I'm sure many of our home care clinicians has seen many of the houses, if not worse than this. And probably we have a lot of stories to tell. So overall, safety should really be the primary goal of all these projects. The home modification professional should really prioritize these concerns within their projects. First and foremost, life safety. Secondly, fall prevention. And third, convenience. When talking about life safety within home modifications, we want to ensure that entry and exits are free of clutter and easy to navigate in case of fire or other emergencies. We want to eliminate the risk for burning. So if I'm making a recommendation for a roll under vanity, we want to make sure that we're insulating the pipes underneath too. So when a patient rolls under with their wheelchair, they're not putting themselves at risk for burning their legs. Utilizing things such as security systems or medical alert systems can help with life safety. And implementing redundancies when possible are definitely beneficial. So for example, with smoke or CO2 alarms, having ones that are set up that provide both visual and auditory alerts if possible, as well as having ones that are not only have a battery backup but are hardwired as well. Fall prevention is something that is very important to me, not only professionally but personally as well. Professionally, as I mentioned earlier, I'm on the fall prevention committee with home care, and we look to integrate ways and ideas to help educate our patients as well as our clinicians to use evidence-based fall prevention interventions if possible to help us out. And from a personal standpoint, several of my family members have fallen because of environmental barriers that are present within the home. And they're not alone. Falls are the leading cause of death from injury and other injuries among older adults. Adjusted for inflation, direct medical costs for fall injuries are $34 billion annually. An older adult falls every second of every day, and 1/3 of falls are directly related to environmental hazards within the home. 66% of individuals who've fallen will fall again within the next 6 months. But there is a silver lining in this. Falls can be prevented. And most fall prevention programs are most successful with the implementation of other interventions and using more of a multidisciplinary approach, as I mentioned earlier. When completing fall prevention interventions with home modifications, it's important to prioritize fall solutions based upon patient need, not just a blanket approach to implementing these interventions. So doing things such as elevating seating and installing grab bars, and putting handrails in on steps, as well as increasing lighting, removing trip or slip hazards, or minimizing threshold or widening doorways are some common recommendations. And finally, when prioritizing home modifications, convenience is something that can help us out. In today's day and age of home automation, utilizing that technology not only helps all of us, as we know through Alexa, but can also help individuals with MS to help conserve energy, reduce the risk of falling, and things of that nature. So utilizing something as Alexa to help those individuals turn on and off the lights without getting up to turn the light switch off. Also tying into possibly temperature controls of the home, as well as tying it into things such as Ring, so they can we're able to see if someone's at the front door for security purposes, and also installing switches and other data access points to be able to control their computer, TV, with things such as just eye gaze or things of that nature as well. This is just another slide about universal design features. It's a cross-cut of a home, and it contains various universal design features. Things such as wider doorways, not only exterior but interior. I recommend 36-inch wide doorways if possible. Some of these older homes, it's difficult to make that happen, but if you're talking about newer homes or you have the ability to make those changes, it's important to use this figure. Also, zero-step entries into the shower if possible. Smooth, durable flooring as opposed to carpet. Wider hallways and stairways to allow not only all individuals to be able to have greater access to the home, but possibly individuals who may be wheelchair bound. It's much easier for them to get around. As well as larger circular areas, especially in the working areas and into the bathroom. We talk about 5-foot circular areas for care in the bathroom. Funding consideration is definitely a hot topic. And something that can definitely make or break a project. The cost of home modifications vary widely. Estimates range for something well under $100 to well over $50,000. Modifications, as I mentioned, can include something as straightforward as installing a grab bar or a pull handle, to something as complex as I've had a couple elevators installed in some of my patients' homes, to completely renovating a home. So we know MS obviously affects individuals physically, but it also imposes financial challenges as well. One statistic that I found is that the overall cost of living with MS is estimated to be over $70,000 per year per person. So when speaking of that, I can definitely see when I'm going in and making home modification recommendations that an individual becomes very worried because how am I going to be able to afford these larger modifications that are taking place? But there's definitely ways to, integrate grant funding or things of that nature to allow an individual to maintain their independence in their home and stay in their home as long as they can. So the modifications, they're not only a benefit for individuals with MS, but it also results in savings for the healthcare system and our economy overall when you're talking about some of those large numbers when we were speaking about falls. And just as you or I would need to determine a budget when we're doing a renovation of our home, it's It's no different than when we're looking at home modifications as well. So if a patient's paying privately, it's not as much of an issue, but that's on the lower percentage of things. When we're looking to complete funding based upon grants, looking into other means of funding, it's important to pull in a social worker onto your team to look at alternative funding sources if possible. And because they vary widely and can often be difficult to obtain, using other resources can definitely be helpful. This is one research tool that I've used in the past. It's from the National Council on Aging. And what I like about it is that it breaks it up into not only listing the resource that's available, but it also gives a good description of what it entails, how much it entails, as well as listing a target population as well as eligibility requirements for that grant or that resource. So just as other aspects of home care and health care, we have barriers that are in place. We also have those barriers for home modifications as well. Things such as covering large geographic service areas can often be difficult, as well as the limited skilled service providers for individuals who perform home modification assessments. However, the use of telehealth features or rehab features is an emerging area of practice that I feel could greatly benefit these individuals. It could increase the number of patients being able to be reached, as well as saving money. In my practice with home modifications, I've tried to get creative at times with individuals that fall outside of my service area, possibly meeting them in Columbus, possibly with individuals as they're maybe getting an infusion, going to a doctor's appointment, having them bring in pictures, drawings, things of that nature, so we can try to troubleshoot and I can provide them with as much information as I can. However, the use of telehealth features would allow synchronous video conferencing to allow me to actually have access to a patient's home and see how they're doing interacting with their home environment. There was a study done in Cincinnati by Marnie Renda. She's an occupational therapist down in that area. And what she looked at was providing home modification services to individuals, both in the normal sense, going into a patient's home, walking through and providing the recommendations there. But she also looked at the ability to use this video synchronous conferencing to be in her office while a caregiver held the little tablet and used something such as Skype, was able to kind of watch the patient go through their homes and pointed out specific recommendations that need to be made. It's encouraging to note that what she found was that the patient satisfaction really didn't change between being in the patient's home and providing that video synchronous conferencing. And also she was able to target many of the same barriers within the home that she would in person. So I definitely see that as an emerging area of practice. As I mentioned earlier, another emerging implication for home modifications is tapping into the smart home features. So partnering with assistive technology consultants to integrate some of these things, not only with structural modifications, but also utilizing things such as Alexa and some of these other features in the home as well. And that kind of leads me into the fact that here at Ohio Health, we have both an assistive technology clinic that we can provide, as well as my home modification program, and it is available through Ohio Health's neuro rehab program. We can serve, and we have served patients both on an outpatient and community side, as well as home care patients who are eligible to receive these services. And without getting too complicated in the semantics of it, just note that if a patient is just needing possibly just a home safety assessment and nothing else, that might be something that could be provided through an outpatient setting to have me go out and see that individual. But if a patient is in need of not only home modification assessment, but also might have nursing needs, have therapy needs, have home health care, home health aid needs, that would be seen more under a home care standpoint. And they would also need to be homebound in that situation. Either one of those two scenarios, a physician's referral would be required for those services. And it looks like I have a little bit of time left, so I wanted to let you know that out of here at the desk, I did provide a flyer for any individuals who may have any interest in the home modification program, as well as provided you guys with my name and contact information. And feel free to come up and ask me any questions you may have after the talk here as well. But does anybody have any questions? Yes?
For the CAP certification,
Mm-hmm.
what does that involve and what do you have to do to maintain that?
So it's a 3-day course, and it's 8 hours each day that you're learning about different aspects of the home modification program, the marketing aspect, the implementation aspect from a building standpoint, and more of a healthcare side to learn more about, for the builders, to learn more about what occupational therapy is, what physical therapy is, and what we can do to kind of integrate and build that team. In order to keep that active, I just did it in October, but I think every 3 years we have to have at least 5 continuing education units to be able to maintain that. Anybody else? All right, thank you very much.